So yes, what was your question?
So for Antimuscarinic, when you say increased stomach emptying will cause acid secretion to increase, is that part of the mechanism that prevents your stomach from emptying, which increases that secretion, or is this post taking the drug?
That would be more likely like post taking the drug, right? So because it's a little bit more of a kind of a viscous compound, it tends to slow things down a little bit, and so that can tend to try to increase gastrin secretion. So again, really the key point for that one specifically with these GI issues is that you're not really using aluminum hydroxide by itself as an antacid. Very frequently you're going to see it used in combination. So the place where you'll see Amphigel specifically being used is going to be for patients who have chronic kidney disease and are on dialysis and they have kind of chronic hyperphosphatemia issues. That's typically where you're going to see it used. Okay. Any other questions from the GI stuff from last week? Okie dokie. So we're going to continue. Oh, yes.
Are we starting as our first line with antacids and then working our way up in terms of titrating, if you will?
That's a really good question. A lot of that's going to depend on several factors, right? So consider your patient that you're dealing with. So for one, if it's someone who has I go out and eat some spicy food and I have some heartburn. Do I necessarily need to be put on a PPI for that? Probably not. Maybe an antacid's all I need. Maybe I just need to buy some Tums over the counter and I'm good to go, right? Maybe an H2 blocker or something like that, right? You also have to look at cost being an issue here as well, because your antacids are going to be the cheapest versus your PPIs are going to be a little bit more expensive. Now we have some over-the-counter alternatives for PPIs that you can use, like omeprazole. So it's a little bit more available, but before they were only prescription only, right? So you'd want to make sure you actually had someone who really had a need for it. If you know they're going to have more consistent symptoms that are more chronic in nature, then that would be someone you want to consider to put on more kind of prophylaxis type therapy. So, if they're having consistent symptoms, then you can consider doing H2 blockers or PPIs. Some people may jump straight to PPIs, especially if the symptoms are more severe, or some people will start with an H2 blocker and then titrate up from there to like a PPI. Yeah, so it's a very good question. But again, as in all things in medicine, it depends on your patient, and kind of what types of, how they're presenting to you. Yep. Okay, so we're going to continue on discussing our PPI. So I mentioned this over-the-counter omeprazole. Again, things to warn your patients about, because the problem with over-the-counter medications is that patients can self-medicate, and so if they don't know the warning signs to look for, then they can be delaying the time when they actually get some treatment for it. So again, if they're vomiting with bloody, black tarry stool, anything like that, they really need to be coming and getting checked out rather than trying to diagnose themselves and take PPIs for that. And of course, anything that's nocturnal heartburn, if they're having lightheaded, dizziness, sweating, anything like that, these are warning things that they probably need to come back and get checked in for. I'm going to pause. Okay, so again, if you look at the actual package insert for these over-the-counter products, again, you see that they will list it as only being approved for people who are over the age of 18. But you'll realize that we do use PPIs in children very frequently, especially if they have more severe GI disease. I think just more information, just try not to make sure patients aren't exceeding over-the-counter recommended dosing. Typically, you're going to see those dosings not be quite as aggressive as the prescription products will be recommended, just so that way the patients that are really having a problem, they can come get checked out. Okay, the next thing we'll look at is going to be our Gastrin Inhibitor. Oh yes.
I just had a question. For peds, when you have babies that are super colicky or have a lot of reflux, are they given these type of meds?
I will frequently see H2 blockers probably being used, especially if they're still in the neonatal period. I don't see a whole lot of PPIs being used. I think H2 blockers like ranitidine or Zantac have been used for much longer. So just because there's more experience and you don't have a lot of studies looking at, especially in the neonatal population, they kind of stick with what they know. So more frequently I'll see that. A little bit older kids, certainly, definitely 2 and up, you can see PPIs being used, no problem. Yeah, but very, very early on, they typically stick with Zantac. Yeah, so I see most commonly. And then also, you have your IV products, so you can give that, there are some PPI products that are IV as well, but like you said, for that age population, they typically go H2 blockers. So the next thing, we have a drug called octreotide. Octreotide you can actually see used for lots of different indications. It's kind of a natural product that your body produces already. It's an analog of a product called somatostatin, and this one actually works to block gastrin release, and we know that gastrin is used in the parietal cells to help stimulate that proton pump and help generate stomach acid. So if you have patients who have a gastrinoma, which is a type of tumor that secretes gastrin, that Zollinger-Ellison or that hypersecretory condition, sometimes you'll see used for severe diarrhea, and this is going to be an IV only product. This is not something you would be recommending for chronic outpatient use. This is something you would typically use more on the inpatient side. Me personally, I would use it in patients from a toxicology standpoint. This actually helps to block insulin release. And so actually sometimes you can use this to help patients who have sulfonylurea overdoses. You actually give this and help to block insulin release and actually help to kind of stabilize their blood sugar a little bit better. Sulfonylureas are a type of drug we use for diabetes that help to secrete insulin. So if you had a kid who accidentally got into something like a glipizide or something like that and they're having hypoglycemia, you can give octreotide to help block that insulin release. So that's one place we'll use it. And then another place you'll see it used is for variceal bleeds. If you're having bleeds or in the esophagus, you can actually use it to help kind of stop that. So that's another case you might see octreotide being used.
Sulfonylurea, is that like metformin?
No, metformin is a different kind of drug. It's called a biguanide, but they're both used for diabetes, but they have very different mechanisms of action. We'll talk more about that probably in Pharm 2, to our endocrine section. So, those would typically be used for, in the most rare of circumstances as opposed to like a PPI or an H2 blocker. So we talked about things that neutralize excess acid. We talked about things that reduce gastric acid secretion. And now we'll talk about things that are working as a mucosal protecting agent. So the first thing we'll look at is colloidal bismuth, otherwise known as Pepto Bismol. You'll also see this referred to as bismuth subsalicylate. And so based on that salicylate name, you're already going to know there's some aspirin-based products that are in there, and who wouldn't you want to give that to? Children, like what type of children specifically? Yeah, or like post-viral, right? If you think you're having a viral syndrome, you would not want to give it to those patients because they're at risk for? Yeah, Ray's syndrome, right? So Pepto Bismol, I'm sure my mom gave this to me way too often as a kid, but fortunately I never had Ray's syndrome. The nice things that this is going to do is help to kind of coat the stomach lining. It's going to help to enhance kind of the cytoprotective effects of that mucus lining that your stomach is already trying to produce to begin with. It helps to inhibit pepsin activity. It's important to know as far as side effects go that this does turn your stool black, right? And so when you see black stool, what do you think? GI bleed, right? So it's important if you're going to give something that changes a patient's urine or feces color, let them know about it, because otherwise it could be, they might think they're having really bad changes when really it's just to be expected. So, and then we mentioned the salicylate issue. There's another drug, which we use this actually pretty frequently, especially in the hem-onc population, but it's called Sucrafate or Carafate. This is a non-absorbable aluminum salt. You can see it's this salt of sucrose octasulfate. And essentially what it does is that when it comes into contact with acid, it helps to form this nice paste. And so it makes this nice coating around the stomach that helps to prevent a lot of that, prevent a lot of that reflux from occurring in the first place. You won't see it used necessarily all the time for GERD specifically. Very frequently I'll see this used in the hem-onc population. They have this issue called stomatitis, where when we talk about hem-onc drugs, you realize that the most rapidly dividing cells are the ones that get hit the hardest, right? So that's why you have alopecia. That's why you have the GI tract takes a big hit because a lot of those cells are rapidly turning over and get inhibited. So in the mucosal lining as well, you can have ulcers that form. It's called stomatitis. And so frequently we'll give this to help kind of coat the mouth and help to provide some relief for those hem-onc patients. So this one can either be given as tablets, but very frequently you'll see it being used as liquid as well, because it can, starting in liquid form, it can kind of help coat things all the way down. And so that way, if you're having the actual reflux, it can kind of deal with some of that gastric acid that's already coming up. Another one, which is not something you'll see used too often, at least I've never seen it used clinically, is going to be something called Misoprostol. The brand name is going to be Cytotec, and this is actually a prostaglandin analog of PGE1. So what this actually is going to be doing is working in those epithelial cells to help enhance mucus production. So it's kind of helping to restore that mucus protective lining in the stomach, rather than dealing with, it'll have a little bit of activity to decrease acid production, but this is really the big place where it's going to be working. This is also could be possibly useful if you have ulcers that are due to insets, because what do we know? What effects does insets have on prostaglandins? Should decrease them, right? So we'll talk about inset-induced ulcers a little bit later, but this could be a possible agent here. You can also see, because it can help to kind of stimulate the GI tract, you can have diarrhea, abdominal cramps with it. It can also, you'll see that it is contraindicated in pregnancy. We'll talk about why that is in just a second. I think I have a slide on this later, but just a thing to note with Misoprostol specifically is that it actually is an abortifacient. Does anyone know what that term means? Abortifacient. It can actually stimulate basically an abortion, right? It's a chemical form of abortion. So they used to use Misoprostol plus methotrexate, which is usually a drug used for either cancer or for certain rheumatologic conditions. So if you had like an ectopic pregnancy or any other reasons, you could give this combination, would actually help to pass that along. And so it's actually kind of interesting because from a hospital religion standpoint, I used to work at St. Vincent's when I was interning as a student. And so one of the things they said is like, hey, we actually don't carry Misoprostol here. And I was like, that's kind of odd. I wonder why they don't. And it's really because based on the religious beliefs of them, they did not believe in abortions. And so they said, well, we're not going to carry this drug, since it could be potential someone could take it and use it on themselves if they had a unwanted pregnancy or something like that. So it's kind of interesting how some of those kind of interplays can occur there. So anyway, looking at the different effectiveness of the agents that you can give to relieve GERD symptoms. We kind of touched on this already when we said, well, who do you give what drugs to, who deserves a antacid, who deserves H1 blockers or H2 blockers in this case. And so you can see here kind of the combination of looking at the cost of the items, see kind of where they fall into line. You'll see kind of the relief they'll provide. And so what do you notice about the onset of relief? Which one has the fastest? Yeah, the antacids are going to be working fastest, right? Because it's dealing specifically right with the acid that's already there, right? Notice also that your duration of relief is going to be the shortest as well, because anytime you're starting to neutralize a lot of the acid, what does the stomach want to do? Send more acid out, right? Because it wants to be able to make sure it's maintaining that homeostasis. So even though the antacids are good at providing some relief there, especially immediately, it's going to be somewhat self-limited. So this is when if you're having continued issues, H2 blockers, PPIs are really going to be the best way to go for those. And really, if you were having very severe, if you had, say, a GI bleed, if you were having any issues, we're having like severe issues of gastric acid secretion, PPIs are probably going to be the way to go, because we already said those are going to be the most potent at decreasing gastric acid secretion. Certainly there may be some cases where I've seen H2 blockers and PPIs being used at the same time for very, very severe cases, but usually PPIs are going to be good enough by themselves. So just kind of keep these relationships in mind in the future. Okay, so as far as going into the GERD treatment, so again, you can kind of look at, based on your symptom severity, you kind of break up into phases as far as what type of medications you'd be recommending for them. So again, with phase 1, if you're only having intermittent, mild heartburn, you can look at doing your lifestyle changes. Antacids would be fine, or you can use over-the-counter H2 blockers, PPIs potentially. Again, if it's very, very intermittent, if they can predict when they're going to have issues, antacids might be the best option for them. If you're having kind of phase 2A, we're having a little bit, you're looking for more symptomatic relief of GERD, kind of on a more consistent basis. This is when you're going to be using specifically more H2 blockers and PPIs. Now, if you're having actual issues of, say, gastric ulcers or having any kind of erosive disease with more moderate to severe symptoms, this is when to either be looking at more high-dose H2 blockers or specifically some of the more, potent PPIs, things like maybe only prescription only, like esomeprazole, pantoprazole. Those are usually the kind of the bigger guns there. And then for your refractory patients, this is when you might have to do some interventional therapies, so where you get into kind of more surgical issues. So typically, a lot of these. Oh, you go ahead.
Like in phase 2B, when we have erosive disease, would you not use one of the mucus protectors?
You could, right? But typically, if the issue with those ulcers is from too much acid production in the first place, it's usually not necessarily due to the fact that your stomach can't produce that protective lining. It's more the issue that is just either too much acid or whatever happens to be. We'll look at Inset-induced ulcers and how that's a little bit different in the pathophys there. But in those cases, if you know it's just an issue of over-secretion of acid and that actual protective lining has no problems with it, then you can just give the PPIs, and that's usually going to be sufficient enough to allow the stomach to start healing itself. Yeah, that's a good question, though. Certainly, adding on a protective agent wouldn't hurt, but you may not necessarily get as much synergy as you might expect from that. Okay. We know that a lot of these patients are going to relapse within 1 year after discontinuing therapy. So you'll see that some patients may require just standard doses for maintenance throughout the years. So again, for more mild disease, H2 blockers will be a little bit more cost effective. And then for moderate to severe esophagitis, proton pump inhibitors are going to be your go-to drugs. And when we said H2 blockers, do you guys remember which one I said to never recommend? It's a C one, yeah. Tagamet, cimetidine. Do you remember why we said not to recommend that? SIP, what? 3A4. Yep, 3A4. Someone the other day said they were really disappointed my license plate didn't say SIP 3A4. But maybe on the next go around. But yeah, so essentially, cimetidine is not going to be the good one to be recommending there because you worry about SIP 3A4 interactions. So next we're going to look at more severe disease. We're going to look at peptic ulcer disease. So we can estimate that approximately 10% of people in the U.S. develop peptic ulcer disease at some point. You're going to see it's going to vary with the type of ulcer we're looking at, age, gender, geographical location. And you're going to see that the prevalence, while it was predominantly male for a long time, is kind of shifting more towards being male and female more equally. So we know that a lot of this is going to be manifesting itself as dyspepsia, but we'll look at a couple of specific types of peptic ulcer disease. So the first one is going to be H. pylori associated ulcers. We'll look at Inset-induced ulcers as well, because again, we want to be able to focus in on drug-induced issues, so the ways we can deal with that. And then we'll also look at stress-related mucosal damage. Like we mentioned with the presentation, dyspepsias are going to be referring to that persistent or recurrent pain or discomfort centered really in the upper abdomen, not necessarily in the esophagus so much. They can have pain, fullness, bloating. That's thought to originate up here in the upper GI tract. So you'll see that with dyspepsia, around 50% of those patients will have a specific problem. So whether it's GERD, this could be a manifestation of, or peptic ulcer disease. So just as a brief overview, if we're looking at the treatment of dyspepsia, if they're on an Inset, first thing you should do is probably just discontinue it, right? If you don't have to be on the Inset, this is going to, again, you're always looking for the most likely etiologies of their issues. And so if they're taking Insets chronically, this is probably going to be the smoking gun. And so if they can discontinue that, perhaps decreasing the dose might help, or we'll look at changing over to a COX-2 specific inhibitor. Have we mentioned any COX-2 specific inhibitors yet? Yeah, I haven't mentioned any of them. So you have ibuprofen, you have aspirin. Those are going to be non-specific inhibitors. So those will block COX-1 and COX-2, right? And so we said COX-1 is really responsible for what? The stomach lining. Yeah, so it helps with the stomach lining. That's that one that is constitutive, meaning it's always being expressed within the body. COX-2 is going to be more inducible, meaning that if you have an injury, if you have some sort of reason for inflammation, that's when that one gets upregulated to cause the inflammatory pathway. So in this case, if you can use a drug that is specifically going to target COX-2 for pain issues and leave COX-1 alone, it can still sit there and produce the gastric protection, right? So the thought here was that by using a COX-2 selective drug, you can help to reduce that effect on the stomach and reduce the number of ulcers and issues of dyspepsia here. So some agents that fall into that category. The main one you'll see being used clinically is going to be called celecoxib or Celebrex. All right, so you guys have probably heard of that one. So that one is going to have the most selectivity for COX-2. They used to have drugs that were exclusively tailored towards COX-2 or selective for COX-2. That ended up causing a lot of cardiovascular death. So if you ever heard of Vioxx, Ever heard of that drug?
Yeah, I've heard of it.
Yeah, it got taken off the market because they were actually seeing increased cardiovascular death due to specific, just total inhibition of COX-2 causing some issues. So we're not going to touch too much on that, but just know that Celebrex or celecoxib is going to be the one that it still has some selectivity for COX-2, but again, selectivity is all on a scale and it's all relative to one another. So Celebrex would be the one that we're kind of referring to there. So, and then if the symptoms are continuing, despite discontinuing the NSAID or using a COX-2 selective agent, then you can start to try H2 blockers, PPIs. On the other hand, if they're not on an NSAID, what is it most likely going to be? Probably H. pylori, right? You guys ever seen the story of H. pylori?
Yes.
Yep. So what happened?
The guy they didn't believe him that it was bacteria that caused the ulcer.
Just some guy, right? Just
some random
random dude. Yeah.
So he drank an inoculation of it and inoculated himself and gave himself the bacteria, which gave him the ulcers, and then he was able to prove it and win the Nobel Prize.
Yeah, so it was actually an Australian physician who he hypothesized correctly that H. pylori were causing all these ulcers. So basically, drank the stuff, gave himself an ulcer, and then he took antibiotics and cured it. So basically, by his N of 1, he was able to kind of get some more headway on that and start some more trials and be able to figure it out. So it's very cool. If you ever watch any, you can search it on YouTube. Just look for the story of H. pylori, and you'll be able to find it. It's actually very, very interesting. So, but we'll talk more about that in a little bit. But basically, if they are positive for that, then you want to treat them for that infection. And then if that's negative, then go ahead and just start an H2 blocker or PPI based on symptomatology. Of course, any alarm symptoms include things like bleeding, anemia, unexplained weight loss. Those will all be big warning signs that they're probably losing blood somewhere and needs to be addressed pretty immediately. So we've kind of, you'll see a lot of the pathophysiology here is going to be similar to GERD, but basically with these duodenal ulcers, you're going to have issues of hypersecretion of gastric acid. And then you can potentially, for gastric ulcers specifically, you may have normal secretion. And if you have non-ulcer based dyspepsia, it could be just normal amounts of secretion, right? It could be an issue with the protective barrier you're dealing with, some issues like that. But typically for duodenal ulcers, because again, that's usually a bit more of a basic environment. You kind of should have neutralized some of those acids. There, it's going to be more really due to our hypersecretion. We know that pepsin is going to be responsible here because pepsin does what? What type of enzyme is that? Yeah, it helps to digest proteins and things like that, but so it's going to be important for stimulating that erosion of the gastric lining, and then also if you're having issues of the mucosal defense or the protection being inhibited, so prostaglandins prevent that deep mucosal injury. We saw that with being stimulatory on that protective mechanism, and you'll typically see it being impaired by either H. pylori or NSAIDs. So risk factors, obviously if you have an H. pylori infection, they'll probably put you at bigger risk for it. NSAID disease, specifically with gastric ulcers, this is really where we're going to see the biggest issue with NSAID use. And then things like genetic predisposition, stress, and then smoking can also be a risk as well. How should they be presenting? If they're having epigastric pain, it could be described as burning, gnawing, aching, non-radiating. And then you'll see that the characteristics are going to differ a little bit based on whether it's a duodenal ulcer or going to be more of a gastric ulcer. Usually you'll see the duodenal ulcers are going to be localized and more relieved by food. And why do you think that is? Yeah, so basically you're digesting that food, it's going to be kind of using up a lot of that acid. So by the time it gets to the duodenum, it's kind of been neutralized to some degree. You can be seeing nocturnal pain or pain 1 to 3 hours after meals once that hypersecretion kind of starts up again, and then it's starting to hit back to the duodenum. On the gastric ulcer side, pain can be at any time of the day, right? Because usually it's going to be more of an issue with the protective barrier, not necessarily so much on oversecretion. Bless you. So for complicated ulcers, you can see issues like GI bleeding occurring, obstruction, perforation. These are the kind of the big ticket items you're really worried about, and hopefully we can prevent by using appropriate treatment for these guys. So as far as treatment considerations go, it's going to depend on the cause of the ulcer. So again, the predominant causes are either going to be H. pylori or NSAID, so deal with one of those two first. If this is the initial presentation of the ulcer, if it's more of a recurrent disease, that can influence what we're going to be using, and then whether other complications have occurred. So obviously, they're already having a massive GI bleed or having a perforation. That's going to be requiring much more emergent management, much more kind of higher, bigger gun type therapy. We're using continuous infusions of PPIs or H2 blockers and things like that to try to help kind of triage that. And then whether or not any, or once we get past that, so the conventional treatment, what you're going to see is that PPIs, H2 blockers, and other agents can heal most of the ulcers in 4 to 8 weeks. And which do you think of those is going to work quicker, PPIs or H2 blockers? PPIs are going to be faster, right? Because they're going to be more, they have a more potent ability to decrease gastric acid secretion. So those are going to work a little bit faster. You're going to see that the gastric ulcers typically are larger, going to be more difficult to heal than the duodenal ulcers, because again, the gastric area is going to always be kind of bathed in those acids versus the duodenum, kind of gets a break. More so than the gastric tissue does. For those patients who are H. pylori positive, some of them will relapse within 1 year with conventional treatment only, meaning if you just use H2 blocker or PPI, you really need to work to eradicate this, the bug specifically. So we'll look at the treatment in order to help to eradicate that. So obviously non-pharmacologic therapies, we talked about some of these lifestyle modifications like eliminating, reducing psychological stress, like maybe not having as many pharma exams, right? Might help. Avoid certain trigger foods, maybe eating smaller, more frequent meals, and then avoiding things like NSAIDs or use decreased doses of it. Potentially you'll see some patients will respond to NSAIDs differently, especially if they're of different chemical classes. So if they respond kind of poorly to ibuprofen, they might do better with something like naproxen, or they might do better with something like meloxicam or other types of NSAIDs. So just be aware that not all NSAIDs are really created equal. Administer them with food might help to decrease some of that effect. And then ethanol and smoking cessation, if you can get your patient to agree to do that. So we'll go over all these different agents as we get through the treatment. So again, most of them we've already talked about. We'll kind of go more into detail in regards to the ulcer specifically. So we see that the healing efficacy of the H2 blockers, 70–95% of patients should be healed up after around 4 to 8 weeks or so. These will definitely be more effective than antacids, and then for the most part, all of them are going to be equally effective. So it doesn't really matter if you like Zantac, if you like Tagamet, if you like famotidine, whatever you like, they're all going to work very similarly. But again, we're never going to recommend Tagamet or cimetidine because of the interactions there. And then why do you think these would be more effective than the antacids? Longer lasting effects. The antacids you have to take around the clock, probably 6 to 8 times a day just in order to help.
People would be more compliant because you don't take them every time.
Exactly. Compliance is going to be better. And then also, by giving H2 blocker, you're not causing the stomach to secrete more acid because of that, right? So the antacids are always going to be self-limited in that regard. Yes?
Would you give an H2 receptor antagonist alone? Or what about a Peptic? What?
We'll talk about that in just a minute. Now that you mentioned that. Yeah, that'll come up in just a bit. So again, looking at the place in therapy, cost effectiveness. So the H2 blocker is going to be much cheaper than PPIs or other therapy. Again, they can be effective in most cases. And then the other benefit is they have IV and liquid formulations available. So again, those are kind of the benefits of looking at H2 blockers. But again, we know they may not be the most effective. But for the majority of people who do not have serious ulcerative issues, these might do just fine. So looking at proton pump inhibitors, again, these are going to provide symptomatic relief. They're going to heal much faster, so they say within 2 to 4 weeks. But if you looked at the absolute healing rates, if you were to compare, apples to apples between H2 blockers and PPIs, the actual healing rates themselves should be somewhat equal. This might just be a little bit faster. And again, any of the agents can be equally effective here. It doesn't matter if you're using omeprazole, esomeprazole, lansoprazole, pantoprazole. It doesn't really matter. They all work very similarly. So the antacids, their role is really going to be for more as-needed symptoms. So if they're having, kind of breakthrough, dyspepsia, this might be a good option for them. It doesn't really matter which one you use. Probably calcium carbonate would probably be the most common one you recommend, just because they're Tums, they're easy, they're over the counter. Again, sodium bicarbonate is probably not going to be very frequently recommended, or it doesn't get used very often. And then aluminum hydroxide, magnesium hydroxide is another good option as well. So like your Maalox is Mylantus. So again, the choice of agent is going to depend on what type of patient you're dealing with. If they have chronic kidney issues, aluminum products are not going to be good for them because they worry about absorbing that and kind of retaining it long term, which can be an issue. If they have issues of kidney stones, you probably don't want to give them which ones. Yeah, probably don't want to give them calcium carbonate. It's not a good option there. So just keep that in mind. Think about your patient and which ones might not be best for them. Also, remember your drug interactions. You can be binding up antibiotics like tetracyclines, fluoroquinolones, and iron products.
What would happen? That's my next question. If they did take fluoroquinolone for the hands?
What do you think happens? Does anyone know?
Tendon rupture?
It's not.
Not tendon rupture. It's not.
Is it a SIB interaction?
Mm-mm. Yeah, binds it up. Absolutely. Yeah. So remember, that's why we said we separate out when you give these. So again, give your take your drugs either an hour before the antacids or say 2 to 4 hours afterwards.
Oh, is this in last lecture?
Yeah, this was in the last lecture. Okay. No worries. It's not like it's on YouTube or anything. So. Just kidding. Okay. So anyway, yeah. So the binding issues are what's important here. So again, if they're binding up your drugs, of course, they're not going to be very effective. So now we're going to look at H. pylori. So we know it's a gram-negative bacteria. We're going to see that this is the most common cause of non-Inset induced ulcers. Again, really your two big etiologies here are going to either be Insets or H. pylori. This is going to be surviving in an acid environment of the stomach. It's one of the few bugs that can really do this and proliferate in this environment. It produces this urease enzyme, which helps to hydrolyze urea in the gastric fluid, and so it'll help to convert ammonia and carbon dioxide. And then it helps to perform this nice local buffering environment of ammonia that creates a neutral microenvironment for the bacteria and helps to protect it from gastric acid. And so this urease is going to be really important when we talk about ways of diagnosing this. So again, most patients who have non-Inset induced ulcers are going to be infected with H. pylori, and eliminating the bug is going to help to decrease the ulcer recurrences, right? And we know that a lot of patients in the world are going to be infected with this. Not everyone's going to be symptomatic necessarily, but a lot of people are going to have this. So probably half of you guys probably have H. pylori in you to some degree. So the other issue you want to worry about dealing with this, because anytime you're constantly kind of irritating the tissue or constantly causing damage, you worry about changing those cells over into cancerous cells. So you worry about the carcinogenic conversion of these susceptible gastric epithelial cells can be a problem. So the three methods that you're going to see H. pylori causing issues here, one, kind of direct irritating effects on the gastric lining. You can see it altering the host immune and inflammatory response, so kind of causing a local inflammatory reaction there, and then leading to a hypergastrinemia, leading to increased acid secretion. Those are kind of the three main mechanisms there. So how do you diagnose it? We mentioned that urease is important because it's producing more urea. So you can do a breath test to determine if they're exhaling extra urea. And so that could be one way to do it. You can do stool antigen tests, which can be pretty selective for H. pylori. And there's also serum antibody tests. If they've had previous occurrences of H. pylori, they'll have some antibodies to that. Okay, so the important thing for farm is going to be the treatment, right? So this is going to be a pretty drug-intensive treatment, either using 3 or 4 drugs typically. And so you're going to see one component is going to be antibiotics. So you're going to see usually clarithromycin, which is what type of drug? No. Macrolide. It's a macrolide, yep. So azithromycin, erythromycin, clarithromycin all fall in the macrolide category. You have amoxicillin, which is a penicillin, perfect. Metronidazole, which we just know is kind of a one-off drug, usually used for a lot of gut infections, and also tetracycline could be used as well. So again, doxycycline and tetracycline can all be used. Then you'll see that you can use, sometimes you'll have combination products. So you have this like RBC combination of ranitidine, bismuth, and citrate. So that's a Tritec pack. We'll talk about how that works in just a minute, how they're just kind of interacting together. Bismuth subsalicylate you'll see used in some of these regimens, and then H2 blockers and proton pump inhibitors. So again, you'll see some combination of all these drugs being used for eradication of the H. pylori and also healing of the actual ulcer itself. So the bismuth preparations, the idea behind using these is that they help to, we know they have that nice kind of local kind of protecting effect, gastric protecting effect. They coat the stomach. And they're also helping to suppress the production of the H. pylori itself. So it has some kind of natural kind of antibacterial activity. So you can see it used in some combinations with ranitidine and citrate, which will help to eliminate that. Notice that no antibiotics are there, so it won't actually get rid of the H. pylori by itself. And then you can also just give the bismuth subsalicylate by itself potentially. And then sometimes you'll see a combination called Helidac, which would have bismuth subsalicylate, metronidazole, and tetracycline. That's that TCN is listed there. So notice you're also going to be given a lot of these pretty frequently throughout the day. Because again, QID dosing is how often?
4.
Yeah, 4 times a day. So they used to recommend 2 drug regimens. They realized that the recurrence of disease was not, it was just too high with that. So they don't really recommend 2 drug regimens anymore. And then you'll notice that with either a 3 drug or 4 drug regimen, that the more drugs you give, the better off you are, right? As in all situations of life, more drugs is better. Not really. In this situation, though, that is the case, where you actually want to do, for the most part, a 4 drug regimen, because again, you can potentially get away with a shorter course of therapy, and the efficacy is going to be higher here. And I'll show you what the combinations are going to be in just a minute. So 3 drug regimens. So for an example here would include clarithromycin, amoxicillin, and a PPI, whatever one you have of choice. And then more frequently you'll have a 4 drug regimen. We'll have bismuth subsalicylate, metronidazole, tetracycline, and a PPI. So notice here, usually using 2 of the antibiotic agents, some sort of inhibitor of gastric acid secretion, and then maybe a protective agent, right? So it's kind of the main crux of the therapy there. And then for failures, if you had patients who are on, say, a 4 drug regimen, they still were having issues with it, you could do resistance testing potentially, and then potentially switching over to something like omeprazole, amoxicillin, metronidazole sometimes will be a better combination for them. So just keep that in mind. So again, you're going to be choosing your regimen based on the tolerability, so how well your patient can deal with it. Obviously, you would not want to give something like tetracycline to what type of patient? Yeah, pregnant and yeah, so like less than 8. Certainly you wouldn't want to give that to them because you worry about what?
Black teeth.
Not black teeth, but just discolored teeth. Yeah. So again, allergies are important. Looking for any drug interactions that might be occurring here, and then look at cost. Compliance can be an issue, especially with things that you're giving more frequently. So if you can do something, especially for patients who are are going to be maybe not as willing to take drugs frequently, especially kids, that can be an issue. So less frequent is better. And then also looking at the antibiotic resistance. So if you're working in an area where H. pylori tends to have a resistance towards one particular drug, it'll lead you towards using a different regimen. If you're having an initial treatment failure, we mentioned kind of switching up your antibiotics from the initial therapy. If you're using a 3 drug regimen, add bismuth on, because again, they'll have some nice protective effects and also help to inhibit the H. pylori. And then use longer durations of therapy, so say 10 to 14 days instead of say 7. All right. So then moving on, we're going to look at our Inset induced ulcers. So they look at around 15 to 30% of chronic Inset patients will end up developing some sort of peptic ulceration, right? So over 1.5% of arthritis patients are taking Insets. It can be a serious GI complication that they can get, including bleeds, perforation, or obstruction. So again, people who are taking these chronically throughout the day for years are going to be more likely to develop these conditions than if you just take it every once in a while for a headache or something. And you'll see it can be a significant risk for hospitalizations with serious GI complications and several deaths that are going to be due to this every year. So your risk factors for who's going to have GI toxicity from NSAIDs, the older your patients are, if they have a history of peptic ulcer disease or GI bleeds, if they're on concurrent use of corticosteroids. Why do you think that is? Decrease what? Doesn't decrease the immunity, or it does, but not necessarily we see increased issues because of that. Yeah, so again, it's working even higher up than the NSAIDs are in the inflammatory pathway. So they're also, by their nature, going to decrease prostaglandin formation, right? So that's why you can end up seeing decreased gastric acid, or decrease that protective layer being formed there because of that. So that can be an issue. If you have high dose or multiple NSAID use, concurrent use of anticoagulants, because again, it's going to make you just more prone to bleeding in the first place. And then any patient who's maybe a chronic major organ impairment, so maybe cardiovascular disease, if they have long-standing CHF, something like that, can maybe predispose them to some of these ulcers. So again, we already kind of alluded to the pathophysiology for this. So again, looking at the direct topical irritation of the gastric epithelium, because we're inhibiting COX-1, so you're going to be preventing that synthesis of the GI mucosal prostaglandin and decreasing the amount of that protective layer that's being secreted, that nice mucus layer that neutralizes a lot of that acid. And then keep in mind that as far as presentation goes, the ulcers don't necessarily correlate well with the absence or presence of pain. So you may have an ulcer there that's really non-symptomatic, but it could still be there chronically. to look at the different presentations, how you might look at H. pylori versus NSAIDs, you'll typically end up seeing NSAIDs being more gastric ulcers than duodenal ulcers. Again, that kind of makes sense because you're directly dealing with the gastric acid or the gastric protective barrier there. You're going to see that the NSAID-induced ulcers are going to be less pH dependent, meaning that things like eating and stimulating gastric acid secretion is not going to have as big of an effect on these NSAID-induced ulcers. They're more often to be asymptomatic, and they usually are going to produce more deep ulcerations and are more likely to have more severe and life-threatening GI bleeding. Right, so these can be really, really significant bleeds you can see happening here. So as treatment goes, obviously you want to stop the drug if you can pinpoint that's what the issue is going to be. So stop that, and if not possible, either reduce your dose, change over to either a COX-2 selective agent like celecoxib or Celebrex, and then also acetaminophen is going to be a good option here as well. Right, so keep in mind acetaminophen might not be okay for all these patients, especially patients like rheumatoid arthritis or something like that, just because it's not really going to pack the same kind of punch as an NSAID would, but it could be an option for some patients. You also want to look to see if they have H. pylori infestation, because then you can actually eradicate that and may actually help. And then looking at agents to use. Your PPIs are typically going to be working more quickly to help with the healing of that ulcer. H2 blockers are going to take a little bit longer, but typically they're going to work. They'll have equal efficacy, it's just one takes less time than the other. And then looking at prevention of these ulcers, again, patients with a history of ulcer on NSAIDs who must continue it, consider putting them on PPIs or H2 blockers in order to help prevent further issues from occurring, right? So if you can't get them off the NSAID, give them something that helps to at least decrease that gastric acid secretion, so maybe you can prevent the ulcer from happening. Again, remember, as high-risk patients, especially if they are, have a history of it, if they're on concurrent anticoagulants or corticosteroids, they probably need to be on some sort of prophylaxis. So other things we can look at, we mentioned the Misoprostol previously. So again, this is going to be that synthetic prostaglandin. So if the NSAIDs are inhibiting prostaglandin formation, we'll just give a synthetic form to help kind of replace it. Again, very frequently I do not see this used all that often, and sometimes you'll actually see it used. They have a product called Arthroattack, where actually you would include it with an NSAID. So instead of taking a different type of NSAID in one of these drugs, you just take the one combination product to help prevent that. But again, it's pregnancy category X. Don't use it for pregnant patients. And then you'll see that as far as efficacy goes, the PPIs and Misoprostol are probably going to be roughly equally efficacious, whereas H2 blockers be a little less efficacious in preventing recurrent ulcers from happening. Looking at the maintenance of the healed ulcers, obviously the maintenance therapy is largely going to be obsolete, but you may consider in patients who have frequent recurrence of the disease. If they're going to be more high risk, like they're a smoker, if they're on chronic NSAIDs, all those things, you may consider putting them on kind of more long-term treatment. But again, if it's an isolated issue where you've gotten rid of the NSAID, you don't necessarily need to put them on maintenance therapy once the ulcer itself is healed. So if the NSAIDs are discontinued or after H. pylori eradication, if you needed to do maintenance, you can consider using low-dose H2 blockers, PPIs. Carafate might be a good option here as well. But if they do have a gastric ulcer, you want to go ahead and use full-dose therapy in order to help prevent that from reoccurring. And then if the NSAIDs are continued, then you want to definitely use probably more like a PPI, just because that's going to give you a little bit more bang for your buck. So any questions on that section? All right, I'm going to give you guys a 10-minute break. We'll come back and continue on with the next section. In case you guys didn't want to vomit before, we're going to talk about antiemetics now. All right. So obviously, your indications for antiemetic drugs, severe nausea, vomiting, motion sickness. You'll see a lot of it being used for postoperative nausea, vomiting, and then also nausea, vomiting associated with chemotherapy. You'll certainly, when you're looking at chemotherapy antiemetic regimens, you'll certainly see some drugs that don't necessarily make sense there based on what you would normally think of as an antiemetic based on this lecture. So if you ever see someone who's getting dexamethasone or something like lorazepam, dexamethasone is a steroid. We know lorazepam is a benzodiazepine. We'll talk more about that in Pharm 2. But just know that those can also be used for nausea, vomiting, typically with chemotherapy-induced nausea, vomiting. So nausea vomiting is a complicated kind of neural pathway that you see happening here. So you can have direct issues, direct stimulants on the GI tract that can cause nausea vomiting, but a lot of it's also happening up in the CNS as well. So you have the chemoreceptor trigger zone, that's at CTZ, that's located in the fourth ventricle, that's responsible for a lot of nausea and vomiting we can see happening here. We know there's a lot of interaction between multiple motor and neuronal pathways, but you'll see that the different drugs are going to be working on different receptor sites in order to help kind of tamp down the system and inhibit it. So we'll go into more detail on all these specific ones. So the first group we'll look at are going to be antimuscarinics, and so this one is very frequently used for motion sickness, especially related to, if you're going on a cruise and you're getting seasickness. This is good for that. So the one we're going to look at here as an antimuscarinic is going to be scopolamine. And when I say antimuscarinic, what do I mean? What type of receptors are those? So muscarinic receptors, what stimulates that? So it's a parasympathetic. Within the parasympathetic nervous system, what neurotransmitter is hitting it? Acetylcholine, yep, exactly. So this is blocking acetylcholine at these muscarinic receptors within the chemoreceptor trigger zone, right? So scopolamine is a big one here. If you ever see transderm scope, what type of product do you think that is? Yeah, it's a patch you're going to put on. So typically you put it on like kind of behind your ear. Keep in mind that this needs to, the patch is applied every 3 days or so, so there's enough drug to drive that concentration gradient to cause absorption. But it does take time to work, right? Because anytime you put a drug on transdermally, it's going to take time for that drug to penetrate through the skin. And so we say wash your hands. And why do I say wash your hands? Well, it'll be on your hands. Usually your skin's, the skin on your hands is going to be thick enough to really prevent a lot of absorption. But you mentioned what? Don't rub your eyes, right? So if you ever see someone who comes in with one eye which is dilated, because we know that if you inhibit muscarinic receptors on the eye, you can cause mydriasis to occur, right? So if you ever see this, you may think, oh crap, they probably have some really bad neurologic condition going on, maybe a brain bleed or something. That's not the case. This is probably just they rubbed their eye and now they have mydriasis in just one eye. So anyway, make sure they wash your hands. Again, you frequently see it used for for motion sickness, but it will cause all of the antimuscarinic signs and symptoms you might imagine. So things like dry mouth, blurred vision, urinary retention, all those things can be seen with this. So not used with extreme frequency, but certainly for like seasickness, things like that. This one is recommended pretty often. So the other thing you'll see is with a lot of the antihistamines, especially the first generation, these are your histamine receptor 1 blockers, right? A lot of these are going to have antimuscarinic activity as well, which is why they work for inhibiting nausea and vomiting. So dimenhydrinate or Dramamine is a common one you see being recommended. Meclizine or Dramamine, Antivert, you'll see frequently being recommended for that. And then promethazine is another one, or Phenergan. Phenergan is nice because it comes not only as an oral product or IV, but also as a suppository. So again, if you're kind of throwing your brains out, then you can just apply it rectally and still get some benefit from the drug there, right? So keep in mind, if you're looking at your second generation antihistamines, why wouldn't they work for nausea and vomiting? Yeah, they don't get up in the CNS. They don't penetrate that, so they're not really going to have much antimuscarinic activity. So again, any of the antihistamines, the first generation could potentially work for this, but these are some of the more common ones you're going to see being used for that. And remember, the side effects you see with those first generation agents, sedation is going to be a big one, and then also you can see similar antimuscarinic activity as you would with the scopolamine.
So one time I used the patch for motion sickness on a cruise, and you're supposed to put it on before you get on.
Mm-hmm.
It made me feel like I was on a boat.
Mm-hmm.
So what happened there?
You sure you weren't on the boat?
Yeah, I'm sure.
Yeah?
I was at home.
It's possible if it could have been... some people end up having some dizziness associated with it. It's not super common. Usually see a lot more sedation more than anything else. But sometimes if it's messing with your inner ear, maybe it had dried that out somewhat and, decreased some of those secretions, maybe that could have affected it. I'm not real sure, but that could be something there. Yep. Okay, the next thing you'll look at, this is probably our major go-to anti-nausea vomiting medications we're using nowadays. So these are your anti-serotonergic medications, which means they're blocking what neurotransmitter? Serotonin. What's the other way I abbreviate serotonin? Nope. It's at 5-HT3. So if you ever see 5-HT, that stands for 5-hydroxytryptamine, which is another way of saying serotonin. So that's how I abbreviate those receptors. So in this case, you have things like ondansetron or Zofran. Everyone ever heard of Zofran before? Yeah, it's great for hangovers, right? You give it in the ED all the time. No, I'm just kidding. That is one reason you might give it. But you give it anytime someone's having nausea, vomiting. But certainly, ondansetron's a very frequent one. Dolasetron I've never actually seen used clinically. And then there's also granesotron or Kytril. I really only see this one being used for really significant nausea, vomiting related to chemotherapy. It's a lot more expensive. It's a little bit more potent than ondansetron. So that's usually where I'll see it being used most frequently. Keep in mind I'm biased because I'm only coming from a pediatric perspective, really, for the most part. But even with the adult, on the ED side, Zofran or ondansetron is like definitely your go-to agent in this category.
So Zofran, there's always these commercials about like for pregnancies, like if you've taken Zofran, please contact whatever. So like what category does it fall into?
It probably falls in category C if memory serves correctly. It's one of those things though that it's especially for very severe nausea, vomiting due to pregnancy. Typically, they recommend actually using a combination of doxylamine, which is a first-generation antihistamine. Usually it's marketed as Unisom for sleep. It's available over the counter, and then it'll also give you B12 with it, right? So it'll give you a combination. There's actually a drug called. It just came out with one. Diclegis is what it's called. It's a combination of B12 and doxylamine, right? So by giving that, they're able to see reduced nausea, vomiting associated with pregnancy, because those are both considered, class or pregnancy category B drugs, right? B or A. Because again, one's just a vitamin. For patients who are still refractory to that, potentially they could even, I've seen them recommend Zofran before. It could be one of those things where, we just don't have enough data to really say whether there's going to be any issues. I don't know if anything has actually been published to say that you do absolutely have, teratogenic effects on the fetus. But again, if your mom's not able to keep anything down, she's getting dehydrated, that's an issue as well, right? I more frequently see issues with some of the other problems like QT prolongation, where that can be a big issue. It's a new black box warning on a lot of these drugs to where you can see increased risk for torsades, especially if you're mixing these drugs with a lot of other QT prolonging drugs, right? It's like fluoroquinolones, macrolides, things like that. So, but yeah, so sometimes you can still see it being used, right? So these are going to be working specifically by blocking the effects of serotonin at the 5-HT3 receptor. That's going to be mainly both in the stomach and in the vomiting center within the brain. They're going to be really effective for chemotherapy. Like cisplatin's a really, really nasty one for causing nausea and vomiting, so this is effective for that. And really, it is pretty well tolerated. You may see some GI side effects like diarrhea, constipation. But the big thing to note here is going to be the QT prolongation. That's probably one of the unique things you want to remember about this category. Yes?
So, if this is most commonly used with cancer patients, are they more susceptible to QT prolongation?
It depends on kind of what their situation is. You don't see a ton of chemo drugs causing QT prolongation necessarily, but they maybe had some electrolyte disturbances. That could possibly be an issue. If they have like hypocalcemia or hypomagnesemia, that could be certainly prolonging your QT in the first place, so that could be an issue. Yeah. These were actually a really big lifesaver. We'll talk about some of the other drugs and some of their side effects, but this really kind of turned things around in regards to nausea and vomiting treatment for chemotherapy. And I'll talk about why that is in just a minute when we look at a few of the other drugs we'll see being used. So the other thing are going to be our anti-dopaminergic drugs. And so obviously these are blocking what? Dopamine, absolutely. So essentially what these are going to be doing is going to be blocking D2 receptors in the chemoreceptor trigger zone. And so one of the things, we haven't talked about it yet, but when we get to our psych meds and we talk about treatment for schizophrenia, you're going to see a lot of those drugs, especially the older generation drugs, were using, they were all D2 receptor antagonists, or blocking the effects of dopamine. And so essentially when you do that, you kind of mimic a certain other kind of disease state. Have you guys covered anything in kind of like CNS conditions? Okay. So essentially when you're looking at someone with Parkinson's, they're basically having a decreased amount of dopamine being released. And so if I give drugs that block dopamine as well, you can actually induce Parkinson-like symptoms. Okay. So back in the day when we were treating patients with chemotherapy drugs that were inducing a lot of nausea and vomiting, metoclopramide used to be one of the few drugs we could give. Sometimes you're using things like prochlorperazine, haloperidol to treat their nausea and vomiting. And it was really the only thing that was being effective for them. Problem is, when you kept using high doses on them, you end up inducing this drug-induced like Parkinsonism. Big issue, right? And so because of that, when the 5-HT3 receptor antagonist came out and didn't really have any of those side effects, it was really kind of a lifesaver for a lot of these patients, because now all of a sudden they did not have such severe side effects associated with it. So always remember, anytime you're blocking D2 receptors, you run the risk of inducing Parkinson-like side effects, right? So kind of disturbed gait, they have that pill rolling, all kinds of skeletal muscle issues that pop up from that. So anyway, so other drugs that are going to do that include the phenothiazines, and so we'll talk more about these drugs when we get to the schizophrenia section, probably in Pharm 2, but just be aware that these are drugs that all block the D2 receptor. The main one I'll focus on for this test is going to be metoclopramide, specifically, or Reglan as it's more commonly known as a brand name. So anyway, these are also going to block muscarinic receptors as well. So again, you can see dizziness, you can see sedation, potential for seizures, and then anytime you're blocking dopamine receptors, you run the risk of producing this thing called neuroleptic malignant syndrome. Has anyone heard of this before? So sometimes you'll see with really high potency dopamine receptor blockers, essentially what it does is you have this thing basically where the skeletal muscle kind of gets contracted and doesn't let go. So you end up developing this kind of lead pipe rigidity they mentioned, so where basically they can't bend their arms, they can't bend their legs like they're used to, and so the muscle gets over contracted and starts to produce heat and acid, and so it can produce very severe metabolic acidosis, can start to produce rhabdomyolysis if it's not caught early enough. So just be aware, it's a very rare circumstance, but sometimes you can see it happen with dopamine blockers.
Is that like tetany?
Yeah, basically it's kind of like a tetany. Yeah. So if you ever see it, it's really, really kind of dramatic when you see it happen, because I remember I was looking at one patient who we were trying to decide whether they're having neuroleptic malignant syndrome or if they're having serotonin syndrome, and basically I was trying, evaluating the guy, and I was trying to have him bend his arm, and I was like, just relax your arm, just relax, man. He said, I can't, like I just cannot relax my arm. It's very kind of distressing to him. He's getting more anxious and kind of worsening the picture. But yeah, it's very kind of interesting when they cannot control their body at that point. So very unique when you see it. Some other things we could use to help control nausea and vomiting. So these would be our cannabinoids, otherwise known as the one that we have marketed as an actual drug product is going to be dronabinol, otherwise known as Marinol. Does anyone know what this is also like? Cannabis, yes, which we just legalized medical marijuana in Florida, right? Yeah. Morgan & Morgan finally did it for the people, right? So essentially what dronabinol is going to be a derivative of delta-9 tetrahydrocannabinol, otherwise known as THC, right? So that's the active component in marijuana that is thought to lead to its kind of pro-appetite stimulation effects. It also helps with the nausea and vomiting associated with it. So you come in these little capsules that you can take, which is basically, marijuana in pill form.
So these have been legal all along?
Yeah.
Before the whole legalizing marijuana?
Mm-hmm.
How come, what makes this legal over,
It's just a derivative product, and they were able to market it. They were able to show that they had, good effects on stimulating appetite in patients who are having wasting syndrome, help reduce nausea and vomiting. Sometimes we'll get this for some of our chemotherapy patients who are still having issues where they're nauseous and they don't want to eat, and we'll actually give this to them, and it'll help with that, so they can help to put weight back on. So, yes.
So if it's oral, do they experience
I haven't talked to the patient specifically to see if they still have the kind of euphoria. You can certainly see that, especially if you're using higher doses. You can see all the effects, right? So you can see the dry mouth, you can see, the CNS effects, having confusion or euphoria, mood changes, things like that. So certainly, because it is reacting with the same exact receptors, specifically the CB1 receptors, that's the cannabinoid 1 receptors, it is acting the same way that marijuana would, cannabis would, and so you'll see the same effects, right? So that's a nice thing you see in chemotherapy patients, primarily to help stimulate appetite and to help decrease nausea and vomiting.
Since we're on cannabinoid and GI, how does marijuana affect people with Crohn's?
Crohn's disease.
Was it Crohn's?
Yeah, I have a friend who has Crohn's disease,
Mm-hmm.
and he swears by cannabis as the
Mm-hmm.
only healing medicine that he's ever taken. He's tried all the Remicades.
Yeah, I don't know. I haven't looked at the data specifically on dealing with Crohn's. If you look up the amendment that was just passed, you look at the different indications where they say, physicians can prescribe based on these things. Basically, they were saying that, I think ulcerative colitis or Crohn's was on that list. So there may be some medical literature out there to show that has been effective. The actual mechanism, I'm not sure. Based on what I know of the disease state, you wouldn't think so, because I don't really think of cannabis as like a real big anti-inflammatory.
Like we learned with Crohn's, you're supposed to stop smoking.
Mm-hmm.
And I know it's different chemicals like cigarettes versus marijuana.
Mm-hmm.
We can eat it.
Yeah, true. I mean, that's kind of the problem with the marijuana-based products. Is like anytime you're inhaling superheated smoke, like you're going to cause damage to the airway, right? That's where you worry about a lot of the cancerous risks and things like that. So even though they say cannabis is safe, like you still are damaging the airway when you're doing that. So maybe edible products, or obviously oral products here, are going to be much better tolerated by the body from that standpoint. Yeah. So again, this might be something you might actually be seeing where patients will be prescribed this for chemotherapy-related nausea and vomiting. You may see that, maybe edible products, whatever it happens to be. I'm not sure how specific they're going to roll this out in Florida, but just be aware you can either see it as dronabinol or Marinol, or you might see it, the actual marijuana product now has been legalized for medical use. Who knows, in a few years, it might be at recreational use. But also to note, if you have any degree of PTSD after this class, this is also one of the indications for medical marijuana. So so you can certainly get a diagnosis and go from there. Yeah. Okay. So so this again, usually you're going to see this mainly in chemotherapy patients. You won't be seeing it used by itself as an antiemetic, but it is nice that it has those products and can help to stimulate appetite, allows patients to try to eat some more. Okay. We also have some really heavy-duty antiemetic drugs we can use. These are going to be substance P antagonists. Does anyone know what substance P is? Ever heard of it? Basically, it's a neurotransmitter. It's kind of the same thing that gets stimulated when you eat spicy foods, right? It kind of stimulates that kind of spice, that pain that you feel when you're eating spicy foods or peppers or things like that. It can also stimulate the GI tract to cause nausea and vomiting. So we have substance P antagonists, which will work centrally to help inhibit some of that nausea and vomiting effects from things like cisplatin or other chemotherapy drugs. So this one is usually used very frequently. If you look at like a drug regimen for a patient who's having a chemotherapy, it's a high metagenic risk, right? So a high risk for causing nausea and vomiting. Typically, you'll see them get something like lorazepam or like a benzodiazepine kind of early on. They'll end up getting ondansetron. They'll also end up getting this drug, Prepitant, as well, and that'll all help to kind of prevent as much nausea and vomiting as you can. And then you'll usually end up doing follow-up treatment as well in order to help prevent that. Because again, it could be very, very significant impact on quality of life. No one likes to throw up. It's always bad, right? So again, you can see, especially with some drugs, you can have both an acute and a delayed response of the nausea and vomiting. So especially with cisplatin, you'll end up giving a dose of a Prepitant within the first 24 hours, and then you'll also end up giving, say, a dose for day 2 and day 3 because it helps prevent that delayed response as well. So it's kind of nice. Again, this is a more expensive drug, really relegated more towards being used during chemotherapy administration. So it's going to be working as an antagonist at this NK1 substance P receptor, and then it will be given with chemo and then on the following 2 days for that. Be aware that it interacts with CYP3A4. It's an inhibitor, so you do need to look at dose adjustments potentially for other drugs. Yes?
Would they prophylactically give this or no, because it's too expensive?
Yeah, so again, if you look at different types of chemo drugs, and a lot of hospitals that administer chemo, they'll have guidelines that say like, okay, cisplatin's a high metagenic risk, something like vincristine is low metagenic risk, and they'll have guidelines based on what type of drug you're getting, the metagenic potential. They'll say, okay, you're going to get this regimen. So for something like cisplatin, they're going to go, okay, we already know that you're probably going to throw up from this, so let's go ahead and give you the high dose regimen. We're going to give you a Prepitant, ondansetron, lorazepam, dexamethasone, just to deal with that. So sometimes they're getting more drugs for the nausea and vomiting than they actually are for the cancer, right? Just keep that in mind.
Is it working on the serotonin receptor too?
No, this is working against the substance P receptors.
Why does it say 5-HT?
So basically they're saying that for the acute phase of the nausea and vomiting, the 5-HT3 receptor antagonists are going to be working better for the acute phase, which is why I give ondansetron early on along with this, and then this is going to help to deal with that late phase nausea and vomiting by blocking that substance P receptor. So this doesn't have anything to do with the serotonin receptors, but it's why we give both drugs together. Yep. Make sense? Okay. Okay, so we also have some prokinetic drugs. So these are going to be drugs that help to stimulate the GI tract. So this is going to be good for patients who have delayed gastric emptying, or if they have gastroparesis, which is a somewhat common effect from what type of disease state? Gastroparesis. So type 2 diabetics will sometimes have this. So sometimes you have nerve damage done to the GI tract where you actually have delayed gastric emptying. It frequently is described as in, like, they'll throw up after eating and the food doesn't look like it's been digested at all. That kind of shows you're not really getting things sent down from the stomach into the rest of the GI tract, right? So a couple of drugs that we can give to help stimulate the GI tract, to help propulse food forward, is metoclopramide. We already mentioned this previously as an antiemetic drug. Again, this is going to be working to block those D2 receptors. They're blocking dopamine, and that actually helps to suppress the release of acetylcholine. Also, by blocking presynaptic D2 receptors, it ends up actually increasing acetylcholine release. Regardless, though, those are more related to its antiemetic actions. But the thing we're looking at here is it actually has strictly a prokinetic action on the GI tract. It's going to help to increase gastric emptying, increase upper GI motility, and increase lower esophageal sphincter tone. So basically, by closing things up at the top and kind of pushing things along, helps to increase GI transit time, or decrease the time actually, because it's increasing the speed of that. So sometimes we give them for GERD, more often for gastroparesis, as I mentioned, and similar side effects to what we already mentioned for this one. Another drug you might see being used to help increase GI motility is going to be cisapride or Propulsid. This one's actually got removed from the market because they saw some issues with both QT prolongation and also some CYP3A4 interactions. This one actually worked by agonizing or activating the 5-HT4 receptors. So notice that there's going to be lots of different serotonin receptors. It's important to make sure you keep them straight. Which ones are working on 5-HT3 receptors, which one are working on 5-HT4. You'll find that certain migraine medications work on different types of serotonin receptors. So just be aware there's differences there. Out of all the different receptor subtypes, serotonin probably has the most variety. It's probably like 14 different types of serotonin receptors. So don't focus on this one too much. Just kind of putting it here just for posterity's sake. The other one you're going to see used probably very frequently in addition to metoclopramide is also going to be erythromycin. I already mentioned this is a macrolide antibiotic. This one is unique because it actually will interact with motilin receptors on the GI tract, and this will actually help to increase motility. So again, frequently seen for diabetic gastroparesis. I see it used a lot in peds patients, especially if they have delayed gastric emptying. This will help kind of propulse things along. And as you might imagine, cramps, impaired motility, you can see some issues there chronically. No, I'm just saying sometimes you'll have kids with other GI issues where they have delayed gastric emptying, right? Yeah. So gastroparesis is not always going to be due to type 2 diabetes, but that is a common cause for it, right? In peds patients, sometimes you'll just have kind of altered anatomy or whatever it happens to be. They have lots of issues with their GI tract that can pop up. Yeah, good question though. Although not to say there's not increased incidence of type 2 diabetic children, unfortunately, especially adolescents and stuff. They're morbidly obese, and you see issues with that. Yep. Okay. Any questions on antiemetics? All right, this is gonna be a real pain in the butt to talk about this. Okay. Now we're gonna talk about laxatives. I've recently just had some major issues with my 5-month-old. We tried to get her started on solids, and that did not go well. Carrots are not good at 5 months yet. About 4 days of just grunting and just nothing, and all of a sudden we're like, let's try glycerin suppository, and it worked. Oh, it worked. So anywho, so we'll talk about laxatives. So their main mechanisms, we can find that they'll either increase motility, the GI tract. They may increase the water content of the stool, and then decrease colonic water and salt absorption, right? So if I'm increasing the amount of water and increasing the volume in the colon, that's going to stimulate it to try to evacuate it, right? Try to get rid of things. So that's mainly the mechanisms we're going to see with our different laxatives. So indications where you might see laxatives being used. So preparation for bowel procedures, so they want to clean out the GI tract, especially if they're doing like endoscopy or whatever type of surgery they want to do. This is a good way to do it. If they are trying to hasten bowel excretion of toxins, so specifically, say for instance, you were to have someone who had, was coming from a different country and they had swallowed a lot of packets of, say, cocaine, right? And you want to help get that out of the GI tract. You can use certain laxatives to help stimulate that and move that along, right? It's one indication. Sometimes post-operative setting, you may have issues with constipation, so you can help to provide some post-operative stimulation. If you want to minimize straining in patients with cardiovascular disease, that's one thing, and then just relief of temporary constipation. Yep. You had a question?
Well, when this happens, like at an airport, let's say, does a doctor have to prescribe these things, or can you just use it over the counter one? Like the police just goes, here, here's this.
The stuff they're using is typically prescription. So have you ever heard the drug called Go Lightly? Yeah, so typically it's used for bowel preparations, but it's basically a hyperosmotic product that they'll ingest, and that will help to kind of just flush everything out, and that's typically a prescription-based product. Yep. So have that, or if you have like someone who was like dealing drugs on the street and they saw the red and blue lights and just swallowed it, that could be another way or another reason to use it to flush things out. Yep.
Is this also given to women, like before, like having a natural birth or whatever? Are they usually given?
Not freak. I mean, my wife didn't have.
They just go
For natural?
Yeah, for natural birth. Yeah. Yeah, I mean, I think some people might recommend it beforehand, like using an enema or something to try to clean things out. Because again, as you're giving birth, like there's a lot of pressure and a lot of pushing going on. So,
A lot of stuff coming out.
I mean, like the baby's coming out, so it's kind of squishing everything on the way down. So it happens. I'm sorry. Yeah. Not typically. Yeah. Because again, they may not want you to like be straining that much prior to getting. I'm not sure why, but they don't. As far as I know, they do not routinely do it, although I'm not primarily a OB-GYN kind of person, so I only have an N of 1 to reference back to, so it is what it is. Anyway, don't let my wife listen to this YouTube video. Just be embarrassed. Okay, anyway, you'll see that a lot of these products are over the counter, and if they have underlying bowel disease, you really don't want to be messing with that unless you know what you're doing. So, just be aware if they have underlying bowel disease, especially over the counter products, these would be contraindicated for self-medication. General side effects you're going to see with a lot of these agents include nausea, abdominal cramps, diarrhea, as you might imagine. And then chronically, you can actually see this issue called cathartic colon syndrome, which is also the name of my alt-rock band in high school. Anyway, so as you can see with chronic administration of some of these laxatives, basically the GI tract kind of gets used to having that stimulation, whatever it happens to be, and so it kind of gets lazy. And so when you take those away, you can run into issues where you're having this mucosal inflammation. You can have atrophy of the outer muscle layers because they haven't had to really work for themselves for a while. Damage to the nerve plexus, issues with the dehydration or malabsorption, and then just disruption of the intestinal flora, that natural bacteria that kind of regulates digestion and things like that. So again, typically we're not recommending laxatives being used chronically, around the clock. Really should only be used kind of on an as-needed basis, right? There'll be some ones we can talk about, some that can be used a little bit more. We'll talk about ones that are more better for like kind of everyday use, and then some that are really only want to use as needed. So the main categories we'll talk about here are going to be either your stimulants or irritant laxatives. We'll talk about bulk forming, which includes things like dietary fiber. We'll talk about stool softeners, and then your osmotic agents. Okay, so the first one we'll say is going to be the stimulants or the irritants, and this is going to provide kind of the strongest impulse in order to evacuate the colon, right? So some of the old ones used to use include things like castor oil. This would help to increase motility and increase water and electrolyte secretion. Nowadays, we have some other agents we use more frequently. So things like bisacodyl, senna, those are probably more frequently being used. And basically, they're just directly stimulating the GI tract to help kind of just propulse things along, right? Especially with the colon, just to evacuate and get everything out. Usually, the main side effects you're going to see here are going to be abdominal cramps, diarrhea, muscle weakness. The biggest thing with the irritant or the stimulant laxatives, those are especially ones where you don't want to use those all the time because the patient is going to, again, lose that natural urge for themselves to have to go. And so make sure you only use it kind of on an as-needed basis. Now, with the bulk forming or non-digestible products, these can be used safely every single day to kind of help regulate normal defecation. This includes things like your psyllium husk, your methyl cellulose. Very frequently, these are coming in powder formulations, so it might be kind of tough for the patients to take cells that they have a hard time, because especially like fiber products, they're typically not real palatable. You either settle out in the liquid, and you're having like real kind of grainy stuff you're trying to get down. So a lot of people don't like it necessarily, but certainly should be mixed with water beforehand. And basically what they're doing is they're increasing in bulk, right, because they like to swell and they'll take up more space when they absorb water, and they'll increase the water content of the stool. And then by doing that, by stretching those receptors out, they're going to cause stimulation for defecation there. So keep in mind that a lot of these fiber-based products can actually bind some drugs. So certainly like your iron products or things like your fluoroquinolones, you can run into potentially some issues there. And then flatulence and cramps are pretty common as well. We can also have some stool softeners. These are essentially just emulsifying the stool, helping to kind of lubricate them somewhat and allow them to be a little bit easier to pass. These are good for things that, like if you're having like really kind of dry, hard stools, these can kind of help stimulate things along. Would include things like mineral oil, glycerin, and then another common one you'll see being used, especially orally, would be docusate, otherwise known as Colace. So again, increasing the water content, lubricating the stool out for easier passage through the colon. And then you'll have your osmotic agents. So we mentioned magnesium sulfate previously. Where do we talk about, magnesium hydroxide previously. We said that one typically causes what? Constipation or diarrhea? Yeah, it causes diarrhea, so that makes sense why I'd use it as an osmotic laxative. And we say osmotic, all we're basically saying is you're providing an hyperosmotic product into the GI tract that allows water to be drawn into it, right? Because water likes to go from areas of high concentration to low concentration, and so by giving hyperosmotic solutions into the GI tract, you're going to cause water to come in, increases the volume, stretches things out, and produces that desire to go. So again, milk and magnesium, you already talked about the green rocket, right? You drink that stuff and you're going to be straight to the bathroom. But you can also see things like lactulose, mannitol can be used for this, and then probably the most common one, especially since I went over the counter, is going to be polyethylene glycol. So this one's very, very frequently recommended. These are also probably okay for everyday use, so it's not infrequent that I'll see patients who get polyethylene glycol every single day. So say 17 grams every single day or one capful. That's usually what they recommend. So Miralax is a common brand name for that one. That's going to be for just kind of occasional relief of constipation. The Go Lightly is the one I mentioned where it actually comes in a big 4-liter basically plastic jug. You reconstitute that with water, and they take that, and that's going to help just kind of flush everything along, right? Sometimes we'll do whole bowel irrigation. I mean, that's what I was mentioning with someone that swallowed drug packets, where you're trying to basically you're giving a continuous feed of Go Lightly through the GI tract, and basically you're just kind of flushing things out until you get kind of a clear rectal effluent, and then you've kind of flushed the whole GI tract out. So sometimes you'll see that being used. Okay, so then you have some anti-diarrheal agents. So these are kind of be doing just the opposite of what the laxatives will be doing. So these are going to help enhance water absorption. They'll decrease GI motility locally as well. And so the main ones you're going to be seeing here are going to be our opioids. So opioids are what type of drugs? Yeah, usually pain medications, analgesics. These are interesting because as we'll find out when we look at opioids probably next semester, is that they very common side effect of them is they slow down the GI tract, cause very severe constipation in a lot of patients. And so what these drugs actually do is that they will not be absorbed into the CNS. They cannot cross the blood-brain barrier, and so instead they'll work just locally at the GI tract to enhance or to activate those opioid receptors and slow everything down. So if you're having diarrhea, it's going to help to slow that down and help to provide a little bit better, well-formed stools. So diphenoxylate and loperamide are the most frequent ones you'll come across. Again, these are available. The loperamide is available over the counter, so you can see that certainly widely available. Interesting, the diphenoxylate is actually co-formulated with atropine. Does anyone know what atropine is? What is it?
Used it like for some sort of activating cardia.
Mm-hmm.
Somebody's kind of vagal, you give them the acid.
Yeah, why is that? What does it do? Mm-hmm. Yeah, so it blocks muscarinic receptors in the heart, so that's why you can see it used for symptomatic bradycardia, right? The other thing it does is if you were to inject a whole lot of it IV, it also makes you super sick, right? So basically what they were seeing is that even though the diphenoxylate, when taken orally, doesn't really get absorbed across the blood-brain barrier to cause euphoria like you normally see with opioids. They were worried about people actually abusing this drug IV, and so what they did is that atropine itself does not get absorbed from the GI tract. So if I just take this stuff orally, diphenoxylate gets absorbed fine, causes decrease in diarrhea. But if I were to inject this IV, all of a sudden that atropine is supposed to make me really sick, and I'll never want to abuse that drug again, right? So that's kind of the reason why you'll see atropine in there. It's not necessarily due to any antidiarrheal activity it has. It's really just as an abuse deterrent.
So this one is oral.
Yeah, both of these are going to be oral.
Okay.
Yep. Yeah, there's no real IV antidiarrheal medications. Yep. So as you might imagine, constipation is going to be the main side effect here. So again, you can always overdo things and kind of cause the opposite problem. You have some exaggerated GI effects, cramping, flatulence, and then you have this issue of megacolon that can occur just over blockage from chronic use of this. What's really interesting that I saw that I don't know if you guys will actually find it interesting, but from my standpoint, so loperamide, the only reason it doesn't really get into the blood-brain barrier is because of a product or a protein called PGP, P-glycoprotein. I already kind of mentioned that before, right? You guys remember what that does?
Shoots up into the GI.
Yeah, so normally it's in the GI tract, and it helps to prevent things from being absorbed too much, right? So if I had a PGP inhibitor, like grapefruit juice, it would allow drug levels to go up for things that are affected by it, because not as much of it is being spit out in the GI tract, right? You have PGP similarly in the blood-brain barrier. It helps to spit things back out into the central circulation so it doesn't get absorbed by the brain, or doesn't affect the brain, right? So one time I actually had a patient who had overdosed on a whole heck of a lot of cimetidine, which is a 3A4 inhibitor, also inhibits PGP, and then took a whole bunch of loperamide. So by doing this, she was trying to inhibit the PGP so that the loperamide would be absorbed, go across the blood-brain barrier, and cause a high.
Wow.
Yeah.
That's a smart.
You'd be surprised how ingenious some of these guys are with their kinetics. Like they research this stuff, and they probably know more about some of this pharmacology than I do, right? So very, very ingenious. Unfortunately, she did not count on the torsades that she went into in the coma. She survived, probably to overdose again, but just be aware. Sometimes patients will do some very odd things, but sometimes there is a method to their madness. So, anywho. You can also use bismuth subsalicylate as an antidiarrheal medication. This is going to help to inhibit intestinal secretions. Can be effective in infectious diarrhea. The big thing you want to worry about with using loperamide or diphenoxylate is not to use them when in infectious diarrhea. And why do you think that is?
You want them to run it out.
Yeah, you want them to try to get rid of all that bad stuff, right? So typically you do not recommend those if you think it's more of an infectious cause. But in this case, bismuth subsalicylate can be useful. It's not really stopping the diarrhea as significantly as you would see with something like loperamide. So just be aware of the salicylate toxicity can be an issue here. Be aware of turning the stool black, all the side effects. Okay, and then moving on. Next, any questions on those subjects? All right. Next, we're going to talk about inflammatory bowel disease and irritable bowel syndrome. Probably won't talk about cannabis for Crohn's because that's news to me. So there you go. So anywho, so when we're talking about IBD or inflammatory bowel disease, you can kind of break it up into ulcerative colitis and Crohn's disease. What's kind of the big difference between these two? Yeah, so Crohn's is kind of, so you kind of said it. So Crohn's is kind of all the way throughout the GI tract. Ulcerative colitis is more affecting the colon, right? That makes sense. Which will be important when we talk about the types of drugs that we're using or the type of dosage forms that we're going to be using for this. So that's going to be important, especially not only for treating patients, but also for maybe some test questions that might come up. So again, Crohn's is going to be much more diffuse. It's going to be affecting the colon, the ileum, upper GI tract. It can be seen kind of all over. Whereas the ulcerative colitis is mainly located to the colon. So again, the rates have remained pretty constant. You can see that certain genetic factors may be influencing this. You can see certain people of different heritage might be more prone to some of these disease states than others. So just be aware of that. There's also kind of a bimodal distribution, so you can see kind of its first peak between 15 and 40 years of age, and then kind of second peak kind of later on between 50 and 80 years. So In a lot of cases, we don't know the exact cause for this. It's probably polygenic, meaning there are several different chromosome changes that might be affecting this. And it appears to be the genetics are more closely correlated with Crohn's disease and ulcerative colitis. But just be aware that, especially depending on your patients, where they're coming from, what their history is, maybe more susceptible than others. So, I'm not going to get super into the etiology because it's not really going to be all that important to our purposes, but just be aware that certainly there may be some environmental factors here. Certainly patients who have been taking NSAIDs might be more prone to this than others. You may see that. Interestingly enough, smoking, well, I think it increases risk for everything. It actually has a decreased risk for ulcerative colitis, so it's kind of interesting. And then there could be some infectious causes as well. But mainly the big thing we're going to be looking at is going to be this kind of immunologic etiology. So you notice here that when you were to take tissue samples of patients with these disease states, they're going to have mucosa that's infiltrated by lymphocytes, mast cells, macrophages, all these things. And you're going to see that IBD is going to be responsive to immunosuppressants. And that's going to be our big thing, is that we want to deal with this inflammation by giving immunosuppressants that will help to decrease that inflammation. You're going to see this is the main brunt of the drugs we're going to use in order to treat these. So again, if you were to have, and of course I chose the wrong color on my text here, so you're probably not copy and paste quite so wantonly. But anyway, so if you were to have normal cells kind of over here on the left side, I can see what the normal function will look like. Whereas in IBD, obviously there's malfunction where the inflammatory cascade is just kind of going haywire and affecting these cells, causing severe breakdown, severe inflammation, and damage to occur. So, again, we're going to be seeing the pathophysiology is mainly due to this inappropriate response of the malfunctioning defense system to normal GI flora and to other antigens that are present in the GI tract. So, the primary, you're going to be seeing this leaky epithelial barrier, disturbed innate immunity in the mucosal epithelium. You're going to be seeing all these antigen processing cells and T cell being activated, and essentially just the immune system is just going haywire, right? It's just over stimulated, reacting to all these different antigens. And so the majority of drugs we're going to be seeing used are going to help to inhibit this pathway. So with ulcerative colitis, we know the inflammation in the mucosa is going to be confined mainly to the rectum and the colon. And we're going to see that the primary lesions are occurring in these crypts of Lieberkühn. You can maybe potentially see pseudopolyps and collar button ulcers, where the Crohn's disease, you're going to see more kind of diffuse inflammation. You can see it happening through the mucosa, submucosa, the musculature. And again, it's going to be seeing most commonly in the terminal ileum, but the inflammation is kind of discontinuous, so it could be kind of having these skip lesions throughout the GI tract. So, as you might imagine, seeing what a normal colon looks like versus the ulcerative colitis, kind of some of the differences happen there. And just some pictures, because I thought they were just kind of interesting, looking between normal, healthy tissue, kind of in the bottom right here, versus like ulcerative colitis. See some of those ulcers happening. Also with Crohn's disease, kind of have these different like aphthous ulcers, or kind of the patchy ulcerations happening there. So anyway, looking at kind of the presentation and how you can kind of differentiate between these two, you can see kind of the common symptoms. Certainly you can see kind of nondescript things like diarrhea, abdominal pain, certainly weight loss, things like that. And then also you're just going to be seeing other signs of kind of overactive immune system. So certainly fever, you can see increased white blood cell count, increased erythrocyte sedimentation rate. All those signs of inflammation are going to be upregulated. Also, you can see possibly some other complications that can occur due to this, because sometimes the inflammation is not just localized to the GI tract, it could be seen elsewhere. So certainly you can see eye complications. You can see this uveitis can happen here. Certainly you can see hemorrhages and perforations of the GI tract. So all kinds of other really bad things can be seen occurring here. As far as diagnosis goes, you can usually do it based on the presentation, family history. You can look at endoscopy and labs and whatnot. And again, I'm not going to get super in-depth into this because you'll probably be covering this in other classes, right? Absolutely. I'm not going to be the expert on diagnosing anything. I'm the drug guy. So anyway, so here are our therapeutic options as far as treatment of ulcerative colitis. You're going to see that we can use either topical or oral immunosalicylates. We're also going to be looking at the use of corticosteroids, because we know corticosteroids do what to the immune system? Suppress it, absolutely. We're going to see other immunosuppressants, and then we're also going to see some of these drugs. They're going to be inhibiting certain parts of the inflammatory pathway. You see things like infliximab, adalimumab. What type of drugs are those, do you think? Yeah, monoclonal antibodies. So are going to see some very specific interactions or side effects and certain things associated with those when we get to them. We'll also look at probiotics. What are probiotics? Yogurt. Yep. What do they do?
Good bacteria.
They're good bacteria, right? They help to restore a normal, healthy gut flora. Look at nutritional support and also potentially surgery could be another option. And then for Crohn's disease, you're going to see that typically have very similar drugs to ulcerative colitis, but can also look at certain antibiotics, which might be useful here, and then potentially some antidiarrheals. The big thing you're going to be seeing as far as differences between ulcerative colitis and Crohn's disease is that sometimes with ulcerative colitis you can get away with using rectally administered medications that are working more locally versus with Crohn's disease, because it is so diffuse and affecting the whole GI tract, you oftentimes have to use more systemic means in order to treat it. So just keep that in mind as we move forward. So first thing we're going to look at are going to be the aminosalicylates. The first one we're going to look at is going to be called sulfasalazine. You may see some different brand names for this, but azolfidine is going to be one of the ones. And then what you see is that a lot of these are going to be prodrugs. You guys remember what prodrugs are? What are they?
They're not.
Yeah, so they're not active by themselves, but they end up getting metabolized and then become active, right? So in this case, you're going to see that it's a prodrug that gets broken down into sulfapyridine and also it's 5-aminosalicylate, otherwise known as mesalamine. That's being metabolized by the colonic bacteria, so basically you're breaking the drug down in order to form these two active components. Again, as you know, aspirin, aminosalicylate, you think as an anti-inflammatory drug, right? The same thing's happening here, so it helps to reduce inflammation by inhibiting cyclooxygenase and also lipoxygenase. And so some of the side effects you can see along with that include things like anorexia, diarrhea, just general abdominal issues, and then potentially even some blood dyscrasias. Don't really see a lot of issues like platelets being inhibited or anything like that, but maybe potentially like some thrombocytopenia might pop up. So then looking at mesalamine itself, or 5-aminosalicylate, you're going to see there's lots of different products that are available here. And so I just list out the different products just to kind of show you some of the differences here. So again, itself is going to be working to reduce inflammation by inhibiting cyclooxygenase and lipoxygenase. Typically, you're going to see it has less side effects than sulfasalazine, so this one probably gets used more frequently. Notice here that you can use certain products which come as tablet formations. Some of them are going to come as suppositories, so you see that canasa there towards the bottom, and there's roasa, which is actually an enema that can be applied. So if you had to imagine, for ulcerative colitis, which one do you think might be more appropriate? Say it was just ulcerative colitis was just, You think Pentasa? Yeah, so ulcerative colitis is just relegated to the rectum and the lower colon. It's a suppositor. Why is that?
Because it won't be systemic, not systemic. You can go right up into there to get.
Okay, good. So would those drugs work for Crohn's disease?
No.
Right. Why?
Because they won't get.
Yeah, no, you're on the right track. You got it. Yeah, they're only going to be affecting kind of the lower colon and affecting the rectum, right? So again, looking at how diffuse the disease is going to tell you kind of what you can use. So again, if it's Crohn's disease, and I know it's affecting kind of everywhere, the tablets are going to be the better option, because I know going from the top down, they're going to be kind of hitting everything, right? Versus if I have ulcerative colitis, sometimes you'll see that if it encompasses too much of the colon, or I guess too much of the colon, you're going to see that these products, these rectally administered products, are not going to be effective, right? Because they're not going to be able to get far enough up in order to affect all of that. So keep that in mind, that if it's more relegated to the rectum, lower colon, this is going to be better to use the suppositories and the enemas. You had a question?
You ever have any toxicities because they'll bypass that first pass effect when they do rectal?
Not really. You don't see a ton of issues with that necessarily. But you're absolutely right. You can get some absorption there that would bypass the first pass effect, but I don't really see any issues. And again, a lot of the times the doses have already been adjusted to account for that. Yeah.
Are they taking this continually?
Yeah, so these drugs will be taken continually, right? Because the inflammation doesn't, only come about with certain, if you're eating or whatever it happens to be like. These are going to be consistently taken chronically. Yeah. What is the difference between a suppository and an enema?
One's a pill. And
How do you give it?
How do you give an enema? Boy, you guys are. These are good. Yeah, these are good questions. We're gonna do practical demonstrations. No.
applicator or something, don't they?
So essentially a suppository. Can anyone describe what a suppository is?
It's got like a small coating on it, and it's inserted.
Yeah, make sure you take the foil off first. I found that out the hard way. Just kidding. So essentially, it's usually some sort of solid dosage form that you're administering. Usually, it's based in some sort of I'm trying to think of the right term.
Like a pill?
It's not a pill, right? Because it's not like a solid tablet or anything like that. It's usually based in some sort of oil-based. It's not wax, but it basically has a low melting temperature, right? So usually like cocoa butter or something like that is being mixed in. The drug is being mixed in with this, and they put it into a mold, so it ends up kind of looking like a bullet almost, right? So this can be administered rectally. The idea is that the cocoa butter, whatever the dose the vehicle is, will melt and allow for the drug to act wherever it needs to, right? So again, it's going to be working usually directly right there in the rectum. The benefit to administering suppositories is one, you bypass that first pass effect. You get decent absorption of drugs, and it's good for patients who can't take things orally, or in this case with ulcerative colitis, you only need it to go and to affect a certain area, the terminal GI tract, right? An enema, on the other hand, is usually a liquid preparation. Usually comes in a bottle with an applicator tip that will be inserted into the rectum. Basically, you usually put the patient on their side, and basically you squeeze, expel the product, and it will usually go up through part of the colon, right? So some of the laxatives we talked about, some of the hyperosmotic ones, are going to be enemas you can administer to help kind of stimulate the GI tract to say, hey, let's get rid of this stuff. In this case, it will be administered to help kind of get further up into the colon in order to help kind of coat that area.
So they really feel
It's not like a plunger necessarily. It's more like a squeeze of a bottle. Usually. Yeah, no, it's fine. And usually the applicator tip is being lubricated. You can insert it into the rectum and then you just squeeze, basically. Right. That's why you put them on their side, so you're not really fighting gravity as much. You could flip them upside down, but patients don't like that too much.
So the suppository you put in it and it stays there.
Usually, right? You want to make sure you get it in far enough, otherwise it could be expelled out. So sometimes, like, you run into issues, especially with infants who have kind of increased motility. Sometimes you can run into issues where if you don't push it in far enough, it'll just kind of come right back out. They'll expel it. Usually adults, it's a little bit easier to get them to kind of cooperate with the, to keep it in there. Yep.
So I'm not visually understanding.
Okay.
So the suppository, is it a device that like absorbs completely, or it falls out once they eliminate after?
No, it's basically it melts. Right. So it's almost like having like a tiny candle or something, right? It just melts in the rectum. Don't put candles there. But basically, like I said, it's like cocoa butter or something like that. It's kind of a common base you see for suppositories, and they have a low melting point, right? So again, at normal room temperature, they're not melted, right? They retain their consistency. But when placed at body temperature, they'll melt, allow the drug to be liberated and can be absorbed.
And then, so then the enema is like liquid going in to help it come out.
So if you're doing like an enema for a laxative purpose, so for instance, if you're doing like a sodium phosphate enema, like a fleet enema, that one you would apply, basically it's a larger volume of fluid that would end up filling up the colon to try to stimulate it to say, hey, there's enough stretch here to stimulate defecation, and it would kind of be expelled, right? And in this instance, when you're applying something like a Roassa, you want to hold that there, right? You want to keep it there in order to help coat the GI tract, or at least the colon, to have the anti-inflammatory actions, right? If you expel it immediately, then it's not really going to get a whole lot of benefit from that. No problem. That makes sense for everyone? Go look at the OTC counter, like at Walgreens or Publix or something. Just look at the products. If you look like at an enema, it'll show you instructions on how to do it with these really awkward pictures, but these little stick guys are laying down their side. Huh?
Do you do it yourself, or do you have somebody do it?
Well, it depends if you have friends, I guess. No, usually an adult could do it themselves. A nurse could do it if they're in the hospital. You could have especially with children, you could have a parent do it. Just depends. This is all being recorded. I love it. Okay, so I'm going to go ahead and cut it here. Is there any questions you guys have about anything else? All right, I'll upload this, and then I will see you guys not next week, I guess, but the following week. Thanks.